All right, everybody, Josh Burton here, continuing on with the COMAT review series lectures. Next topic, infectious disease. Kind of a big topic here. We'll try to hit all of the high-yield stuff that will be most important for the test here. Namely, HIV, AIDS, tetanus, rabies, a couple vector-borne illnesses, and a couple others that seem to pop up more so than others when it comes to the infectious disease component of the test questions. Let's start off with HIV. So infectious agents here, so bodily fluids, looking for semen, blood, vaginal secretions, breast milk can all be conduits for HIV transmission here. Usually gets through damaged tissue, mucous membranes, blood. Highest risk is receptive anal intercourse. There has been a couple test questions there as far as what is your highest risk of getting HIV. And then a couple other ones too. So there's a window period between the acute HIV infection and then the chronic state, and that's where the viral load is highest and where patients are more likely to transmit the virus to someone else. And so it's the window period between those two areas. AIDS infection, so this is a CD4 count less than 200 and or a defining illness. We'll go through each one of these here. These are the real high yield ones to know. So PCP pneumonia, cryptococcal meningitis, CNS toxoplasmosis, Capacitor, capociosarcoma, oral candidiasis, herpes zoster, and then CMV retinitis. Anytime we're talking about these immunocompromised states and these defining illnesses, one thing to know before we get started is if it's an HIV patient, the most common cause of pneumonia is still the common bug. It's not the PCP pneumonia. It's the Streptococcus pneumonia, the H flu. And so if there is a question that is, what's the most common cause of pneumonia in an HIV individual, it's still common things being common. They are at risk for pneumocystis pneumonia, which we'll talk about. But as far as the vast majority is still the common bugs there, which would be the Streptococcus pneumonia and H flu. With that being said, let's jump into pneumocystis pneumonia here. So most common opportunistic infection in HIV. It is the leading cause of death. Your chest x-ray usually shows this bat wing-like appearance. So all this opacification in this area here, kind of on both sides, in the right clinical setting here. So immunocompromised patient, fever, shortness of breath, septic. This is what we're talking about. Most common cause of pneumothorax in AIDS patients is due to a pneumocystis pneumonia. And the treatment is typically moving forward with Bactrim or an IV pentamidine. Some questions will come up with, should you add steroids onto the regimen or not? And there is a criteria for that. That includes if they got a PO2 less than 70 or an AA gradient that's greater than 35, then they warrant steroids. And there has been a question that's come up before where they'll give you a picture of an individual who's HIV positive, shortness of breath, fever, concern for pneumocystis pneumonia. In addition, or ask, what treatment should be pursued or what management should be performed, and it'll give you, Bactrim, all the different antibiotics to choose from, and then one of the answer choices will have steroids as an option as well, and it's our job to know, hey, if the PO2 is less than 70, if the AA gradient is greater than 35, then I need to add on steroids to this regimen as well. Next one to go over is cryptococcal meningitis. I think we all remember this one from medical school as it has that India ink prep stain that we're looking for. This question classically comes up on test questions for sure. CT scan is pursued to rule out or to assess for intracranial masses. You get the CSF studies with the India ink prep. That's done on the CSF fluid there. And you get that cryptococcal antigen titer. Treatment will be amphotericin B. Did not include this one in the seizure lecture, but this also can cause seizures in an HIV patient. Next one to talk about is CNS toxoplasmosis, so most common cause of focal encephalitis. It is the leading cause of intracranial mass, which you see here, intracranial mass lesions in AIDS patients. Again, treatment, pyrethamine and sulfadiazine. Next one going down the list is the Capacitor capociosarcoma. This is the most common cancer in AIDS patients. It's mostly on the skin of the distal extremities. So you get these reddish, brown, bluish colored kind of subcutaneous nodules, papules. Most commonly you'll see them on the face, the oral cavity, genitalia, feet. They're painless or non-pruritic lesions. Kind of a spongy texture might be one of the descriptors in the question stem. but most frequently seen on the distal extremities. Next one is oral candidiasis. So again, you're looking for that raised white lacy plaque on the tongue, a buccal mucosa. Potassium hydroxide prep is the diagnosis. Clotrimazole atroche or nystatin suspension will be the treatment of choice there. And if you suspect esophageal candidiasis or Candida esophagitis, usually there's like a painful swallowing that's in there as well. So if that is included in the question stem, think Candida esophagitis. Consider diagnosis of AIDS if not already known, and then treatment for that would then be oral fluconazole. Herpes zoster infection. So again, it's a reactivation of varicella virus. Lesions are infectious until they crust over. We treat with acyclovir. That is that classic description, that unilateral or follows that dermatomal distribution, has that vesicular in nature, very painful. And a couple of these do have some kind of high-yield board associations or test question associations, one of which is complicated zoster, the herpes zoster ophthalmicus. So if you get that Hutchinson sign, or if there's involvement of the tip of the nose, that it should clue you in on that the eye is also involved, and should do a fluorescein evaluation for those dendritic lesions. There's herpes zoster oticus, where you have that vesicular rash that is included into the ear there. Another name for that is Ramsay-Hunt syndrome, which commonly comes up. And then if it's disseminated in the immunocompromised patient, it can lead to things like pneumonitis, encephalitis, and hepatitis. Again, that usually becomes a very severe infection. CMV retinitis, this is the most common ocular complication in AIDS patients. On fundoscopy, you'll get these white perivascular infiltrates kind of all through this area here. Here, let me turn on the laser pointer. So again, here's some white perivascular infiltrates kind of along this area here, and then it progresses out into this hemorrhagic necrotizing retinitis, over on this area here. Big issue here, can lead to blindness, and then you're treating with foscarnet or ganciclovir. I feel like typically the answer choices usually include ganciclovir, but I have seen both as options, and so good to know both as far as this diagnosis goes for treatment. The next question that can come up commonly is post-exposure prophylaxis. So the highest risk of transmission in this situation would be a hollow bore needle plus infected blood. The patient does end up having HIV. The 3-drug regimen includes emtricitabine, tenofovir, and raltegravir. It is a 28-day regimen unless the patient is found to be HIV negative. It's kind of a lot to know, but the big one I think that I've seen on the different Q banks is for post-exposure prophylaxis, what's the highest risk of transmission for HIV? And it's that hollow bore needle plus infected blood. All right, let's move on to tetanus. A lot of things to cover with tetanus, but it seems like the vast majority is, do you give the vaccine, do you give the immunoglobulin, or do you do nothing? And it's always, someone who, traumatic accident, there's a wound that's involved, and then either they're, completely immunized, there no immunizations have been performed, which is this top one here. So really kind of how I remember it is, kid grew up in a household, was not pro-vaccines. They did not receive any of their vaccinations as a kid. Now they have this dirty wound or this burn that's happened. What do you do? And it's a vaccination plus the tetanus immunoglobulin. Other than that, you're just given the vaccine, unless they've had more than 3 doses in the last 5 years, which is a common question in the emergency department, and we do update a lot of tetanus vaccines there. But the one that they always will get you on is, did you just give the vaccine or did you give the vaccine plus the tetanus immunoglobulin? And where that one comes into play is they were never vaccinated. They have no idea, if they've gotten it or not. And they have this wound that is not considered minor, which includes, a wound that's contaminated with, feces, soil, saliva. It's a puncture wound or saliva with puncture wound. It's a burn, crush injury, something that's much more than just, like an abrasion or like a small laceration kind of deal. And it's been, more than 6 hours old or appears infected on initial presentation. So that's the big takeaway there. Other than that, if they need to be updated on their vaccine, then update the vaccine. Next one is rabies. Lots of questions on rabies for some reason. It always seems like the bat always gets included into the question stem. So most common animals involved: raccoons, skunks, bats, foxes. Outside of the U.S. and Canada is dogs. But it seems like the vast majority of all the questions that I've been going through have been a bat was found in the room, or the children woke up and they found that there was a bat in the room overnight, and you're unsure if there was a bite or not. The concern is that it is transmitted through the saliva into the bite. Clinically, you get that hydrophobia, the agitation, the spasms, and all the questions always revolve around the treatment. So it's usually scrub the wound, vaccine plus the immune globulin typically is the answer there. And so you're unaware if you've been bit or not. Bat was found in the room, give the vaccine, and give the immunoglobulin. The vaccine is given over multiple days, and so you might see an answer choice where it's, give the vaccine, and then it's given on days 3, 7, and 14. That's how the vaccine's done. And then the immunoglobulin goes right into the wound. So if it's in the hand, it's going in the hand. And if you can't fit it all there, then the rest of it goes intramuscular away from the vaccine. That's probably a little bit too much detail, but just kind of complete the rabies as far as that treatment goes. That's how it's performed. Next one we'll move into our vector-borne illnesses. We'll start off with Lyme disease. Everyone loves Lyme disease, and we all got to know it. Loads of things that we can talk about with Lyme disease, right? So starting at the top there, it is the Ixodes tick. Carries Borrelia burgdorferi. On the skin, you get that hallmark erythema migrans, or the targetoid-like rash that you see. Neurologically, it is the infection that causes that bilateral Bell's palsy, which does seem to make its way into a lot of question stems. Cardio, it can cause myocarditis, it can cause AV blocks. If it was someone who was exposed to it, it's doxycycline, just one-time dose. Otherwise, you're looking to treat with doxycycline, and sometimes they kind of throw a curveball, like, well, what if they're pregnant? What if it's a pediatric patient, in which case it'd be amoxicillin or cefuroximine to avoid the adverse or the side effects of doxycycline in those patient populations. Excuse me. Next one here is Rocky Mountain spotted fever. Loads of different test questions on this one here. So this is the dermatocentaur tick. Carries Rickettsia rickettsii. Causes that high fever and that centripetal-like rash. And treatment of choice is doxycycline. And so the big clue on this one is the type of rash that's included. And so it's a blanching-like rash that you kind of see here. Classically, it starts on the flexor surfaces of the wrists, the ankles, and then it moves to the palms and soles, and then it goes centrally towards the body and kind of covers everything. And that's described as a centripetal rash, not a centrifugal rash. I've seen it both ways, where they'll describe the rash, progressing from the wrists and ankles and going, centrally, or just saying there's a centripetal rash on exam, and you kind of need to know the two different ways on how that is defined. But treatment is the same with doxycycline. Next one is malaria. So you have P. falciparum causes the most severe disease there. The vivax and ovale are the ones that go dormant, which typically get asked about. And then there's the cyclical fevers that come into play. So there's every 2 days, that's the falciparum, vivax and ovale, and then every 3 days is malariae. And I've had a couple questions where it's, every fever is every 2 days. Next question is fever every 3 days. And so that is good to know kind of how to differentiate those as far as test-taking purposes go. Classic question, what's the most common, diagnosis needed to be performed? That'll be that thin and thick smear. And then treatment in sensitive regions is chloroquine resistant. You got the quinine plus doxycycline or atovaquone and proguanil. And if it's a complicated malaria case, then it'll include into the treatment choices. I would go with artesunate is how I would say that. Hopefully that's right. But again, recognizing the cyclical fevers and making the diagnosis of thin and thick smears, I think have been a lot of the test questions have been framed around that there. Next one through is biological warfare. There's a lot that kind of come into this, and it can get pretty detailed, but we'll just stick with the most common ones, namely smallpox or variola, which presents with the high fevers for 2 to 3 days, and you get this maculopapular rash. And the big descriptor here is those lesions are all at the same stage of progression, which differs it from other rashes, right? So smallpox, same stage of those lesions, most contagious early on, around 4 days or so. Treatment, you got contact, airborne precautions, vaccinate within 4 days of exposure, and that includes the most of it there. But largely is what's the most common diagnosis, and you're going to see those lesions at the same stage of healing, and that's what clues you in. Hey, this is smallpox, is real disease here. Next one is anthrax. So cutaneous anthrax is the most common one, more than 95% of the cases, typically associated with contaminated hide, goat hair, wool, that sort of thing. There's different types. So inhalational is rapidly fatal. The GI is the severe abdominal pain. You get hematemesis, hematochezia. You get that chest x-ray that shows that mediastinal widening. So again, there's that cutaneous picture there, where sometimes you get the picture to kind of go along with the test question versus a descriptor of it. So there's a small, painless, pruritic papule, enlarges, becomes vesicular, and then edema comes on, and then it becomes associated with fevers, malaise, and then near about the end of the week or so it ruptures, and it turns into this black eschar, and that's usually the question or the picture that you get is this black eschar associated with that cutaneous anthrax. The other one is the chest x-ray, so inhalational. This is another cause of a widened mediastinum. So we talked about that with aortic dissection. If you change the question stem around, and now you're looking for hey, is this biological warfare type presentation, and you're thinking inhalational anthrax, and you get a chest x-ray with a wide mediastinum, that's the clue in that you're on the right track. Treatment, fluoroquinolones. All right, a couple other ones just to round this one off, make sure we're hitting all the high yield ones. So legionella pneumophila comes in quite a bit. It's one we always remember, right? It's the air cooling towers, evaporative condensers, shower heads. It's the pneumonia plus diarrhea. Common electrolyte abnormality is low sodium. The diagnosis you made from a urinary antigen assay, and then you treat with azithromycin. But commonly comes up, a good one to know for test questions there. Next one is toxoplasmosis, so common in immunocompromised. I don't like to see it in newborns. Transmitted from cat feces and progresses into like a CNS infection. So you get that CT scan with IV contrast, and it lights up these brain mass lesions here. Very poor outcome. Treatment, pyrethrin and sulfadiazine, and sometimes they'll have with folinic acid, sometimes without, but those are the two main ones that we're looking for as far as treatment goes, and recognizing, where it's coming from. We're including, cat litter in the question stem, or it's a pregnant patient who, got involved with, a cat or exposed or something to that effect. Now you're worried about, congenital infections, that sort of thing. Next one is Ebola, so direct contact with bodily fluids is how that one is transmitted. Clinically, you get the fevers, chills, headache, conjunctival injection, the diffuse maculopapular rash, and then bleeding is the big one there. And then treatment, unfortunately, is all supportive care, so early aggressive, oral IV hydration, correct coagulopathies, electrolyte repletion, that sort of deal. All right, guys, and that is all. Thank you.